Over its 65-year existence, the Air Force Medical Service has grown and changed, even as the Air Force has grown and changed. One characteristic has remained the same: quality. Beginning in World War II, under Major General David Grant, new methods of supporting our warriors were being developed. Colonel Malcolm Grow, later the first Air Force Surgeon General, personally developed a new armor suit for the 8th Air Force.
A great deal of planning and battle experience have gone into the development of this body armor. We found that 80% of all battle wounds were caused from relatively low velocity missiles from flak and 20mm cannon shells.
In September 1947, the Army Air Forces gained independence from the U.S. Army, but some U.S. Air Force support functions, such as medical care and the chaplain services, remained under the Army. In 1947, Brigadier General Grow, who succeeded General Grant as Air Surgeon, began a campaign to win Air Force medical independence. In the summer of 1949, Air Force General Order No. 35 established the Air Force Medical Service. About 3,700 Army doctors, nurses, and other medics transferred to the new Air Force Medical Service. When the Medical Service issued its first Officer Corps badges, designers chose the sign of Aesculapius, the ancient Greek god of healing, as a corporate symbol. The Air Force Medical Service emblem also carried the staff of Aesculapius. In the fall of 1950, the heavy United Nations casualties in Korea almost overwhelmed the meager U.S. medical resources in the Far East. FEAF medics responded with hard work and courage, helping United Nations combat units to rally and eventually drive out the North Korean invaders. To cope with the rush of casualties in 1950, Air Force H-5 rescue helicopters of the 3rd Air Rescue Squadron went into action as frontline medical craft, and the Army soon set up its own helicopter evacuation service. C-47 transports of the 315th Air Division, carrying aeromedical crews, also flew into the most forward airstrips, even under enemy fire, and saved thousands of American lives. The 801st Medical Evacuation Squadron was one of the first units to receive a Distinguished Unit Citation for its evacuation of more than 4,700 casualties from the Chosin Reservoir. Many 801st flights originated from Sinanju Airfield in late November 1950, where 2,700 patients were evacuated. The 801st MAES enabled the embattled 1st Marine Division at the Chosin Reservoir to execute a successful fighting withdrawal to the northeast coast of Korea. By 1953, the Air Force's C-47s and C-54s evacuated most of the war's casualties. The Korean War also established the medical service's need for air-transportable hospitals. But it was not until 1955 that the first airborne medical units containing 36 beds were purchased for testing. They went into active service in 1959 as part of the new 1st Medical Service Wing, whose first commander, Colonel Robert A. Patterson, later became Surgeon General. As the Cold War darkened, the Medical Service found that its wartime mission, size, and structure were still valid. In 1957, the Lackland Air Force Base Hospital became the Air Force's largest medical facility with 500 beds. 2 years later, another 500 beds were added. By 1963, the Lackland Hospital was the flagship of the Air Force Medical Service and was renamed after Major General Wilford Hall. During the early 1950s, the Air Force Medical Service began to focus increasingly on its core specialty, aviation medicine. Researchers began to explore the aeromedical problems of new jet fighters and look forward to the space age. Led by Colonel John Paul Stapp at Holloman Air Force Base, New Mexico, medics and engineers probed human physiological limits to develop safer ejection and crash systems. Other Air Force physicians experimented with extremely high altitude effect on the human body. Assisted by Air Force doctors, officers like Captain Joseph W. Kinninger Jr. experimented with bailouts at altitudes above 100,000 feet. One of the most important supporters of aviation medicine was General Bernard A. Schriever, head of the Air Research and Development Command. In 1949, Major General Harry G. Armstrong, the second Surgeon General, began to support manned space exploration. He established a Department of Space Medicine at the School of Aviation Medicine and appointed several former German Air Force physicians, led by Dr. Hubertus Strughold, to explore this new field. The professor had an important influence on space development in the following decades and would be known as the father of space medicine. By 1959, the Air Force realized that aerospace described its mission better than aviation. In the 1960s, Air Force medics dedicated themselves to relieving the suffering of war in Southeast Asia. Air Force flight surgeons and other physicians, dentists, nurses, and medical technicians deployed to South Vietnam and Thailand. The rapid evacuation for Vietnam's battlefield by helicopter and jet transport saved many lives. Army helicopters picked up most battle casualties shortly after they were wounded. Pacific Air Forces operated a scheduled in-country aeromedical service and also a transoceanic jet service to the hospitals at Clark Air Base, Philippines, Yokota, and Tachikawa Air Base in Japan. In August 1968, under Surgeon General Kenneth E. Pletcher, the Air Force acquired its first specially designed aeromedical jet, the C-9A Nightingale. Because of advances in aeromedical evacuation, personnel wounded in Southeast Asia were much less likely to die than in the Korean War. The high quality of Air Force medicine helped sustain Air Force effectiveness in the Vietnam War. Back at home, the Air Force Surgeon General Lieutenant General Richard L. Bohannon strengthened programs to ensure a healthy and fit fighting force. The aerobics physical fitness program, developed by Lieutenant Colonel Kenneth H. Cooper, was adopted in January 1970. The Air Force began to promote aerobic fitness, running, swimming, and bicycling in the 1970s. Starting in 1978, when Dr. George E. Schaefer was Surgeon General, military planners concluded that in cases of conflict, air bases in Europe would probably suffer many more casualties than previously estimated. In November 1979, the Air Force Medical Service began a series of medical red flag exercises to test its wartime readiness. Surgeon General Paul W. Myers initiated the exercises. Tents and modular steel boxes were combined to make the first modern air-transportable hospitals. In the early 1980s, under Surgeon General Max B. Bralier, the medical service began to pre-position several large contingency hospitals abroad. Special reserve units were created in 1982 to help the active duty medical force staff these contingency hospitals in wartime. Surgeon General Murphy A. Chesney continued the modernization of air-transportable hospitals through the 1980s. The medical service completed a 5-year program to enlarge the standard 24-bed air-transportable hospital to 50 beds. The new design was also more flexible, providing for 14, 25, or 50 beds. By mid-1990s, the Air Force had more than 24 50-bed air-transportable hospitals. Most were attached to the continental United States Tactical Fighter Wings for rapid deployment. In August 1990, Surgeon General Monty B. Miller led the Air Force Medical Service into its largest deployment since the Vietnam War. Rapid deployment was the keynote in the Persian Gulf. The 1st Squadron, medical elements, and air transportable clinics left the United States on August 8, 1990. just one day after the first fighter deployments. And until September 1990, when Army and Navy medical teams arrived, Air Force medical units were the chief medical support available in Southwest Asia. The 50-bed air transportable hospital could be carried by 6 C-141 aircraft. Once on site, weather and other conditions permitting, the ATH staff and base support units could erect the hospital usually within 24 to 48 hours. In Desert Shield, most of the ATH equipment worked well in the harsh desert climate. Each ATH could function for 30 days without resupply. Each ATH had a 19-person decontamination team to handle chemical warfare casualties. These hospitals were designed to meet the medical needs of a deployed tactical fighter wing with up to 72 aircraft and about 4,000 people. Desert Storm fighting, fortunately, produced only a small number of casualties. From August 1990 to March 1991, disease and non-battle injuries accounted for most of the patients evacuated from Southwest Asia. Aggressive preventative medicine was effective in minimizing the losses to disease. Orthopedic injuries alone accounted for about 43% of the evacuees. Although not tested in full, the Air Medical Readiness System created in the 1980s showed that it had more than passed the test. Humanitarian and peacekeeping operations around the globe have been one of our missions since 1949. From victims of earthquakes in Europe to orphans and refugees in the Vietnam War, Cuban refugees in the 1980s, to hurricanes in the United States in the early 21st century, high-quality Air Force medicine has always been readily available. After the collapse of the Soviet Union in the early 1990s, the new Surgeon General, Alexander M. Sloan, supported the increased tempo of Air Force humanitarian and peacekeeping operations. The medical service became active in supporting operations in the Balkans and began to make its air transportable hospital and aeromedical evacuation systems even more flexible and responsive. In 1994, Surgeon General Edgar Anderson Jr. began to reduce the medical service's overall size and reorganize its basic operations for new missions. The goal of Air Force medical readiness is the rapid response to support theater commanders while maintaining a high level of readiness with a smaller, more mobile medical footprint. Surgeon General Lieutenant General Charles H. Rodman led a vital partnership initiative called Mirror Force, which promoted active duty, guard, and reserve personnel, all working together as a seamless, integrated medical service. In 1999, more than 300 Air Force medics deployed to the Balkans. From March to late June of that year, USAFE was active in Operation Allied Force in Kosovo, and later the humanitarian Operation Shining Hope, for ethnic Albanian refugees fleeing Kosovo to Albania and Macedonia. This marked the first large-scale deployment of Air Force Medical Service contingency units that had been re-engineered in the 1990s based on lessons of the Gulf War. The Balkan deployment showed that the medical service had chosen wisely in recent years by continuing to emphasize lightness and flexibility in its ongoing re-engineering of deployable medical assets. The new Expeditionary Medical Support System, or EMEDS, became the standard configuration of deployable medical facilities from this point on, where EMEDS allowed for smaller and more tailored responses. The Critical Care Air Transport Teams, better known as CCAT, allowed for critical care in the air that in turn enabled critically ill and injured patients to be moved more quickly to higher levels of care. CCAT, which was championed by the 17th Surgeon General P.K. Carleton, along with the EMEDS, became the foundation of the Air Force's flexible medical response in the 21st century. On September 11, 2001, terrorists attacked New York's World Trade Center and the Pentagon in Washington, D.C., and the world changed. When Operation Enduring Freedom kicked off a few days later, the Air Force responded deploying specialty teams, EMEDS units, air evacuation capability, and eventually its larger theater hospitals. This conflict saw Air Force medics pushed farther forward into the fight than ever before. In August 2005, when Hurricanes Katrina and Rita struck, Air Force active duty, Guard, and Reserve medics were in place, conducting life-saving operations. Teams ensured safe evacuation of over 2,600 patients. On September 3, 2005, teams moved 580 litters and 300 ambulatory patients, the largest single day of transports since Korea. In 2005, Congress directed another round of base closures. Lieutenant General Peach Taylor, the 18th Surgeon General, shepherded the Air Force through the first difficult years of BRAC in 2005. This piece of legislation directed the merger of Brooke Army Medical Center and Wilford Hall Medical Center in San Antonio, and the closing of inpatient activities at Malcolm Grove Medical Center, located at Andrews Air Force Base, Maryland. It also moved United States Air Force School of Aerospace Medicine from its historic home at Brooks Air Force Base, Texas, to Wright-Patterson Air Force Base in Ohio, and consolidated most medical training to the Joint Medical Education Training Campus at Fort Sam Houston in San Antonio. In 2009, the AFMS, under the direction of Lieutenant General James G. Roudebush, implemented the successful Family Health Initiative, better known as Patient-Centered Medical Home. The goal of achieving better health outcomes for patients was built on a team approach with a partnership between patients and their healthcare teams, critical to creating better health and better care via improved continuity. The U.S. was still at war in Afghanistan and Iraq as the next decade dawned, but a drawdown of forces was on the horizon. Lieutenant General Charles Bruce Green headed the medical service as the Air Force Theater Hospital in Iraq ceased operations in November 2011. During its operations by the Air Force, more than 35,000 sick and wounded had passed through its doors. Both the hospitals at Balad Air Base in Iraq and Bagram Air Base in Afghanistan saw the lowest number of patients die of wounds in American history, with 98% of those who reached medical care surviving thanks to new innovations and better processes. In early 2014, Manas Air Base in Kyrgyzstan ended its operations after 12 years. By the end of 2013, over 52,000 medics had deployed, and over 103,000 patients had been evacuated during operations Enduring Freedom, Iraqi Freedom, and New Dawn. The next century poses new challenges for the Air Force Medical Service to response to advances in medical technology, a shifting economy, and changes in national medical doctrine. To help meet these challenges in both wartime and peacetime, Lieutenant General Thomas Travis, the current Surgeon General, implemented a strategy to achieve the AFMS vision of ensuring our supported population is the healthiest and highest performing segment of the U.S. by 2025. Readiness. The AFMS must ensure all airmen are ready to meet contingency requirements. The Air Force's most valuable asset is its people. They deserve and must be in the best physical, psychological, and emotional health to meet the challenges both at home station and in the AOR. The core mission of Air Force medics is to provide full-spectrum care, no matter what the military operation: humanitarian, combat operations, stability operations, disaster preparedness, and homeland defense. Better care. The AFMS continues to endeavor to provide patients with positive experiences and outcomes. To do this, medical personnel must be consistent and reliable in ensuring staff focuses on patient safety first and use evidence-based practices in the provision of quality care. Better health. It is a challenging time for medical providers nationwide, with increasing rates of obesity and chronic illnesses. The AFMS strives to motivate patients to be proactive and involved in their health by providing a culture that promotes both resiliency against physical and emotional challenges, as well as optimal human performance. Best value. The medical service focuses on the appropriate utilization of people and resources applied through effective management of the AFMS enterprise to achieve our goals and targeted goals and vision of trusted care anywhere. The Air Force Medical Service continues to maintain a tradition of high quality and mission effectiveness that has been its distinguishing feature in the DoD medical community since 1949. No matter where in the world airmen are sent, they can depend on the same high standard of care, whether in peace or in war.